Hello everyone. Today my group and I will critically evaluate the Corona clinical trial, focusing on colchicine in treating non-hospitalized COVID-19 patients. Severe COVID-19 complications are often driven by excessive inflammation, particularly through activation of the NLPR3 inflammasome. This triggers a cytokine storm, leading to outcomes like respiratory failure, multi-organ dysfunction, and death. Colchicine was chosen because it inhibits the NLPR3 inflammasome, blocks IL-1 beta release, reduces cytokine storms, and decreases leukocyte recruitment and adhesion. It's oral, safe, affordable, and widely available. These features made colchicine a promising candidate for reducing inflammatory complications in early-stage COVID-19. At the time, there was no strong evidence supporting effective oral outpatient therapies. Most studies on colchicine were observational or unpowered, where some data showed potential benefits. Corona was the first large-scale and randomized outpatient trial. A well-powered study was needed to assess colchicine's impact on preventing serious outcomes and guide early community-based intervention. This was a phase 3 randomized double-blind, placebo-controlled international multicenter trial. It enrolled 4,488 participants across 6 countries. Eligible patients were aged 40 plus, with PCR confirmed or suspected COVID-19, and at least one risk factor such as diabetes, obesity, or hypertension. The intervention group received colchicine 0.5 milligram twice daily for 3 days, then once daily for 27 days. The control group received a visually identical placebo. Given the lack of approved outpatient treatments, using a placebo was appropriate. The primary endpoint was COVID-19 related hospitalization or death within 30 days. Study strengths include its Golden State design, central randomization, blending, large international sample, and subgroup analysis in PCR-confirmed cases. However, masking could have been improved. The study didn't assess blending effectiveness. We could ask participants and the staff post-trial if they guessed their group to evaluate this. Also, using a placebo with mild GI effects may better mimic colchicine and mating blending. Next, my group members will continue by discussing other aspects of the study. Thank you.
Hello everyone, my name is Changshu Li, and today I'll be talking about the result of the Corona trial and the statistical meaning behind the data. The trial aimed to evaluate whether colchicine could reduce the risk of COVID-19 related deaths or hospitalization within 30 days in community-treated patients. Among PCR-confirmed patients, 96 out of 2,075 in the colchicine group experienced the primary endpoint, giving an event rate of 4.6%. In the placebo group, 126 out of 2,084 patients were affected with an event rate of 6%. This difference is illustrated in Figure 4. To compare these rates, the author used the logistic regression model, which produced an odds ratio of 0.75 with a 95.1 confidence interval ranging from 0.57 to 0.99, and the p-value is 0.042. Since the confidence interval is not cross 1 and the p-value is lower than 0.05, the result is statistically significant. Subgroup analysis shows that the most notable benefit was observed in male patients. In this subgroup, the odds ratio was 0.67 with a 95 confidence interval from 0.48 to 0.95, which is statistically significant. In contrast, when the analysis includes the entire study population, not just those with PCR-confirmed COVID-19, the result was not statistically significant, as the confidence interval included 1 and the p-value was greater than 0.05. To better understand the statistical meaning, we calculated several common measures. First, the relative risk is calculated by dividing the event rate of the colchicine group by that in the placebo group equals 0.77. Then the relative risk reduction is is calculated as 1 minus the relative risk equals 0.233. Next, the absolute risk reduction is the difference between the two event rates, which gives an AR of 1.4%. From there, we calculate the number needed to treat as 1 divided by the ARR, that is approximately 71. Finally, a chi-square test was performed to produce the p-value of 0.0417, which is below 0.05 and indicates as statistically significant. For the clinical significance, according to the NNT of 71, we would need to treat 71 patients with Coach-Sign to prevent 1 hospitalization or death. The RR of 23.3% shows a meaningful relative reduction risk. And the AR of 1.4% tells us that for every 100 patients treated, 1.4 fewer would experience serious COVID-related outcome. Importantly, the greatest benefit was observed in male patients, where the treatment effect was both clinically significant. Lastly, looking at the safety profile in Figure 5, serious adverse events were slightly lower in the Coach-Sign group. However, GI side effects were more frequent with Coach-Sign. Based on this, we calculate the number needed to harm, which is 11, meaning 1 additional GI side effect occurred for every 11 patients treated. Despite this, there was no increase in serious complications, and the overall safety was acceptable. Thank you for listening. I will now hand over to my group member to discuss the limitations.
There are a few limitations in the COCORONA study which may impact the application of the study findings, with the assumption of a primary endpoint event rate of 7% in the placebo group, an approximation of 6,000 patients with 3,000 patients randomly allocated into the treatment groups was the initial target. However, due to logistical, personnel, and budget issues during the pandemic, the study has ceased recruitment when 75% of patients were recruited and completed the 30-day follow-up. This reduced population size may have been a factor in the missed statistical significance of the primary composite endpoint between the colchicine and placebo groups, where the p-value was only 0.081. Taking into consideration of the number of participants who had withdrawn, did not get consent, or discontinued, the overall population was reduced, which may have contributed to the missed statistical significance. Additionally, there was around 7% of the participants in both treatment groups that had lacked PCR confirmation of COVID-19 due to restrictions early in the pandemic from a shortage of reagents for PCR tests. Due to this shortage, initial recruitment of patients who had an epidemiological link or compatible symptoms to COVID-19 were also recruited. This may have diluted or affected the results of some patients may have not had COVID-19, and these patients had shown half of the primary event rate compared to those who were confirmed with COVID-19 via PCR testing. Furthermore, participants that had a confirmed diagnosis of COVID-19 showed greater statistical significance in the primary efficacy endpoints. Another limitation of the study was the duration of follow-ups, which was only 30 days, which did not assess the long-term effects of COVID-19 on patients, and whether colchicine would have any effect after 30 days or help with the persistent COVID-19 symptoms. Additionally, the short-term effects of less than 30 days are not entirely investigated as well. Another limitation was that COCORONA was conducted in December 2020. Hence, the results would have been more applicable to the alpha strand of COVID-19. Future variants such as Omicron, which was first identified in November 2021, was deemed to be a variant of concern due to the number of mutations and novel mutations in this variant. An increased infection rate was seen. With the evolution of COVID-19 and different variants such as Omicron and the development of vaccines, future investigation in the application and effects of colchicine on COVID-19 will be required, targeting vaccinated populations and different variants. Changes to the eligibility criteria, such as adding participants have a confirmed PCR COVID-19 test to be included in the study, could prevent weakening of the observed treatment effect, as patients may have not had COVID-19. Despite the logistical, personnel, budget issues, and shortages in PCR tests during pandemic times, COCORONA has given an insight into the effect of colchicine on COVID-19 related clinical events. With improvement and alterations, further trials are needed for different COVID-19 variants and vaccinated populations to determine the effectiveness of colchicine. I'll now pass it to Eugene, who will discuss the potential conflict of interest in the study. Thank you.
Thanks for Andrea's introductions. My name is Wu Yujun. Now let's discuss the conflict of interest related to this study. The funding for this trial comes from multiple independent sources, which are listed here. Some researchers also report receiving personal feed from university, government agents, and companies other than pharmaceutical science. These companies, universities, and institutions have not been found to have any connection with pharmaceutical science. Therefore, based on the currently available public information, this is no evidence that these parties could have influenced the independence of the study. According to the statement from Professor James Long-Cloder Taddeuf and Professor M.P. Dubey, they have 5 patents which may influence the transparencies of the trial, which are also listed here. 2 of these patents are owned by Professor Taddeuf's institutions. However, Professor Taddeuf has waived his rights to any patent related to the cognizance, meaning he would not receive financial benefit even if cognizance were adopted as a treatment of the COVID-19. The other 3 patents are held generally by both professors. Almost with 2 general to non-relatives, and the remaining one provide relatives that are assigned to the Material Health Institutes. Therefore, it can be considered that investigators are unlikely to receive any essential financial benefit from this clinical trial, and the independence of the trial remains unaffected. From a public source, we know that Pharmaceutical Science is a Canadian pharmaceutical company founded in 1983, and it is privately held. On clinicaltrials.gov, Pharmaceutical Science was registered 7 clinical trials before. Most of these were conducted in Birmingham, with only 1 in Canada. None of the investigators involved in these studies overlap with the investigators of the current trial. In this case, Pharmaceutical Science has no evaluations of the study designs, data collections, statistics analysis, or manuscript preparations. Their rules was limited to supplying the study medication. Therefore, based on the correctly information, Pharmaceutical Science is unlikely to have influenced the independence of this trial. In summary, the trial is confirmation of purchase procurations and independence, the funding source, and investigation personal financial interests were not directly connected to the pharmaceutical companies. The investigation are unlikely to get directly financial benefits from the study. Therefore, potential bias is unlikely to materially affect the study outcome. That's all. Thank you.